is a lot of information to be found on this chart, so it will be divided into two voiceover recordings for your listening. Because the brain is so complex, it is difficult to anticipate the exact reaction an individual will have to a specific drug. Many systemic effects can be anticipated when giving a medication that changes the central nervous system, and the actual actions within the central nervous system are not clearly understood for many of these drugs. The choice of which drug to use depends upon the situation and what adverse effects may be produced by using the drug. There are several classes of anxiolytic drugs. Anxiolytics themselves prevent feelings of tension or fear. Sedatives calm and make patients unaware of the environment, while hypnotics cause sleep, and minor tranquilizers produce a state of tranquility in anxious patients. Our first class of drugs are the benzodiazepines. They are the most frequently used anxiolytic drugs and prevent anxiety without causing much associated sedation. Additionally, they are less likely to cause physical dependence than many of the older sedative hypnotics that are used to relieve anxiety. The four drugs in this class that we are talking about this semester are alprazolam, diazepam, lorazepam, and midazolam. All of these are in the benzodiazepine class. For all benzodiazepines, individuals who experience an overdose of the medication will be given a drug called flumazenil, which is the antidote for all benzodiazepines. Each of these drugs are given for anxiety. Some may be given for panic attacks like alprazolam. Diazepam can also be used preoperatively and for seizures. Lorazepam can also be used for anxiety and is often given to patients who are undergoing chemotherapy. Midazolam is used for sedation for procedures such as colonoscopies and can also be used to cause sedation in an individual who is mechanically ventilated. The adverse effect for all of these drugs are the same. They can cause dizziness, drowsiness, lethargy, which is increased with the use of alcohol or other CNS depressants, and can also cause patients to experience constipation. With long-term use, these drugs can cause tolerance and dependence upon them, which is not a good thing, so they're mostly short-term use drugs. These drugs may not be stopped abruptly. They need to be tapered because they can cause withdrawal syndrome, which are nausea, headache, vertigo, and nightmares. You need to use them cautiously with older adults because of the dizziness and drowsiness that occurs. And these drugs have many drug interactions, so you need to be very careful with what drugs are also being given with this class of drugs. The barbiturate used as a hypnotic that we chose was phenobarbital. It inhibits neuronal impulse conduction and depresses the cerebral cortex, and is frequently used for patients who experience seizures, but it can also be used to cause sedation. It can cause an oversedation and coma. Patients may feel hung over the next day. They just are not quite as oriented and alert as they usually are. Can cause hypotension and, of course, respiratory depression. This drug irritates the veins, so you can develop phlebitis at an IV site if it's being given IV, so you need to be careful watching that IV site. And it has more severe effects than some of the newer drugs, so it's not used as frequently. It also causes a physical tolerance and dependence, so the dose needs to be tapered. This is the first drug that we are talking about this semester where you have serum levels that need to be monitored to make sure the patient stays in a therapeutic range. The serum levels for normal phenobarbital are normally 15 to 40 mics per milliliter. So anytime you see serum levels listed on the chart, be sure you learn this information and you understand that what the ramifications are. If under the lowest level of normal, then the patient is not getting a therapeutic effect. If over the therapeutic level, So in the case of phenobarbital, a serum level of 45 indicates this patient is probably going to experience more of the adverse effects than they would if their serum levels were within the normal limits. The other drug out of this chapter that we chose was azopiclone, and it is used to treat insomnia. The caution for patients who take this drug are that they need at least 8 hours of sleep because of the risk for experiencing next day impairment, and they call this sleep driving. So the patient will get up and they may go to work and they don't remember how they got up, they don't remember getting dressed, and they do not remember driving to work. They may experience abnormal behaviors and memory loss and have some loss of coordination. So making sure that they get enough sleep is very important if they're taking this drug. The tablets must be swallowed whole. They cannot be crushed because of the way the drug is distributed in the body, and the dose needs to be tapered as well as for the other anxiolytic drugs. Chapter 21 discusses antidepressants. And the first class of antidepressants we are going to talk about are the tricyclic antidepressants. They are used to treat clinical depression, which is a very common disorder that results in feelings of sadness. The choice of drug depends upon the patient's individual response and their tolerance of the adverse effects. They block the reuptake of serotonin and norepinephrine, and they do have some sedative effects, so these drugs are effective with depression that has some anxiety and sleep disturbances as symptoms of the depression. If there are many drugs in the class, and so if one drug doesn't work, often another drug will be tried to see if it's more effective. And typically, as you switch between the drugs, you allow 4 to 6 weeks for the body to sort of get back to normal, and then you try the new drug. These drugs have long half-lives, many drug interactions, so you want to be very careful with starting and stopping them. Additionally, stopping abruptly will cause withdrawal syndrome, as we've already talked about. The contraindications are numerous, and some of these are directly related to the anticholinergic adverse effects of tricyclic antidepressants. I've listed the symptoms of an anticholinergic adverse reaction, which are dry mouth and eyes, blurred vision, constipation, and urinary retention. For all the drugs that we talk about this semester, and we talk about anticholinergic effects, these are the effects we're looking for. So for the male patient who has benign prostatic hypertrophy and has trouble emptying their bladder, taking an anticholinergic drug will cause that to be worsened because of the urinary retention. So pay attention to that this semester. Tricyclic antidepressants are not prescribed for children. The next class of these drugs are the MAO inhibitors, monoxamine oxidase inhibitors. They have the same precautions as the tricyclic antidepressants and are not used very often due to the dietary restrictions. Patients who take these drugs must avoid tyramine-containing foods, that is, fermented foods such as aged cheese, red wine, balsamic vinegar. There is a chart on page 362 which describes these drugs or these foods, and you need to be aware of this because this is something you will need to be teaching your patients who may happen to be on an MAOI drug. Again, the central nervous system symptoms are dizziness, but the patient may experience mania, which is the opposite of their depression. They may experience orthostatic hypotension, or on the other extreme, may have a hypertensive crisis. So monitoring the blood pressure is definitely something you want to be doing for a patient on an MAOI to ensure that they are not experiencing a blood pressure crisis. These drugs are also cause liver toxicity, so you will be monitoring the patient's liver enzymes to make sure that their liver is not being impacted by the use of an MAO inhibitor. Any over-the-counter medication should be cleared for use with the provider because of the drug-drug interactions that occur with the use of an MAOI. Phenelzine is the drug that we chose out of this class to talk about this semester. And the next class of these drugs are the selective serotonin reuptake inhibitors, or the SSRIs. They block the effects of 5-HT reuptake, so the serotonin reuptake is blocked and it results in an antidepressant effect. Escitalopram and fluoxetine are the two drugs we chose out of this class. Fluoxetine is the only one of these drugs that is approved for use in children older than 8. However, there is an increased risk of suicide in children and adolescents who are taking fluoxetine, so they need to be monitored carefully. I've listed the uses of the indications for these drugs. Typically, depression and anxiety are what they are used for, although in unlabeled use, they were not approved for it, but it seems to help. There are several of those drugs listed there as well, or conditions. For the whole class of drugs, they can cause sedation, the dry mouth, nausea, and diarrhea. Upper respiratory infections, URI, upper respiratory infections can occur with these drugs more frequently, and something called neuroleptic malignant syndrome, which is directly related to that effect of the drug on the central nervous system. So the signs of neuroleptic malignant syndrome are muscle rigidity, fever, autonomic instability. Patients can also experience insomnia, suicidal thoughts, sexual dysfunction, and tremors. It takes about 4 weeks until you see the effects of these drugs, so you need to make the patient aware that it's going to be a little while before they see any effects, and the drug is usually taken in the morning. You need to avoid taking it with tricyclic antidepressants or MAOIs and with St. John's wort because of the interaction from the herb. Serotonin syndrome is another issue for these patients as an adverse effect, and the symptoms of serotonin syndrome are mental changes, agitation, hallucinations, coma, and an increased sensitivity to light. So you need to teach your patients to watch for these type of adverse effects when they're and to report them if they occur.